All right, it's 8 o'clock according to my watch, so we'll go ahead and get started. Good morning, and thank you all for coming to this virtual lecture on CPT coding. I'm Sandy Archer. I'm a professor here at the University of Kentucky College of Medicine, and I believe many of our residents are on board with us. If you haven't already done so, please take the moment to mute your microphones and use the chat function at the bottom of your screen if you want to ask questions that I'll try and answer toward the end of the discussion. So perhaps getting ahead of myself a little bit, but this could be the most important lecture that you get in terms of your training. And if you are a practicing physician that's chiming into my presentation this morning, it's even more important that you understand how to properly code. As I go through this, the more I do these talks, the more I learn from these talks, and the more I understand how important proper coding is for our practices, both academic and private practice. So without further ado, we'll talk about coding tips and strategies. This talk is not meant to be all-inclusive, but will highlight many of the topics that are important for basic understanding of coding, as well as some more advanced strategies that can help you dramatically in your practices. Why me? Well, I've been involved in a lot of things with our academy over the years in terms of coding and resident education. And I won't go into all of these things, but probably the most important thing I'm known for is our CPT code book that I publish every couple of years and give to our residents and faculty and others at request. So why bother? What's the big deal about CPT coding? Well, it all boils down to covering your practice expenses and bringing money into your home. And in this day and age, that's become even more important as we're limiting our practices and reducing our patient encounters and surgical experiences. And we're always dealing with healthcare plans. Some plans are better than others. Some have more difficult times in terms of getting things pre-authorized. So if you're not doing proper coding and documentation, then you will not be able to get the appropriate reimbursement that you deserve. And it's all about what you deserve. So this is basically about your practice, whether you're a resident who will be going into practice or someone who is already in practice. If you're not doing this properly and correctly, you are wasting money and you're wasting your time. So you really need to understand that everything we're doing in medicine these days is RVU related. And so if you look at the Medicare conversion factors, back in 2008, look at what the rate was. It was almost $40 per RVU. And now and it dropped substantially with Medicare changes in 2017, and it's slowly creeping back up. But look at the improvement we made from last year to this year. A whole nickel on every RVU. Hardly seems worthwhile compared to the almost $40 we were receiving back then. CPT coding changes every year, and the Federal Reserve Register publishes the new codes in November in the Congress documentation. And in 2020, we had 248 new codes across all specialties with 75 revisions and 71 deletions. And so this is terribly important because if you're using an outdated code, you will get your reimbursement kicked back at you, and it could take up to 3 months to resubmit and reclaim the monies that are due to you on that office or surgical experience. And so again, some insurance plans are a little bit better than others in terms of paying, and so sometimes you just have to do what you have to do. For those who work with me in the program, they know that I code everything myself, and I advocate that everyone else code everything themselves as well. This could be somewhat onerous, but quite frankly, it doesn't take long to do this. Most practices, you're using probably maybe 20 to 30 codes on a regular basis, and sometimes you'll have to look up some codes that are less frequently utilized for your practices, but you should know your CPT codes for your procedures. The E&M codes are usually posted on your super bill and can be easily marked. And more importantly, you want to make sure that you're using the proper terminology for ICD-9 coding. So if you're not doing the ICD-10 coding, so if you're not doing your ICD-10 coding yourself, at least put in the verbiage so that your coding manager or office personnel can find the proper ICD-10 code that'll correlate with the CPD code that you're of the procedure or the visit that you're performing. And so that's the importance of doing the technology part of it. And once again, if you're not documenting what you did in your note, it does not matter what you code, because if you can't support your coding with your documentation, you will not get reimbursed. And so this is where insurance companies will come back and tell you that they're only going to pay a level 2 instead of a level 3, a level 1 instead of a level 2, or that you may not get reimbursed for a surgical procedure performed because you forgot to include the turbinate reduction in your septoplasty operation, and you just discussed that part of the operation alone, even though you coded and performed both. So years ago, Medicare eliminated consult codes. And so we don't really use that often for Medicare, but commercial carriers may still continue to use consultation codes. And so you should code everything you do appropriately, and your coding people, the people that submit your bills, will correct that discrepancy when they send it to the appropriate insurance company. So they're the ones that know who does and does not accept these codes. But you should always code what you've done, and hopefully you'll get reimbursed for that. So what is let's talk about just office visits for a moment. A new patient visit is basically someone who comes in to see you that has not been referred or asked for a consultation by another physician and has not been seen in your practice in 3 years. Now, what's important to understand is that if you have a practice that has subspecialties, if you have an otologist who's seeing a patient who has a nasal problem, they can consult you regarding the nasal problem, and you can bill for a consultation, as long as the documentation is proper from the consulting, from the the physician requesting the consultation. And so one of the important things here is that new patient visits are 3 years. So if you saw someone over 3 years ago and you're seeing them for same or dissimilar complaint, you can bill them as a new patient. Now that's really up to your discretion. If you've seen them 3.5 years ago for a sinus problem and they're back again, you could decide whether or not you want to bill a new patient visit. Sometimes the patients, because they will see their EOB, explanation of benefits form from their insurance carrier, will argue with you that they are not a new patient. And that's something that you have to come to terms with in your head as to how you want to bill those patients. But a consultation is important because it does bill at a higher value, and it does provide, and you do provide a higher service than just seeing a new patient. So in order to actually describe this as a consultation, another provider has to request the service for you of a specific problem that you're documenting, and you have to have all 3 components of the visit, just like any other visit: the history, the physical, and the medical decision making. The reason for the consultation needs to be documented in your note, and most importantly, you need to send a letter back to your physician that referred the patient for consultation, or else this is not deemed a consultation. You cannot really use the word referral in your terminology for a description of the consultation. For example, if you were to say, Mr. Smith was referred by Dr. So-and-so for this problem, that is incorrect terminology and will not be considered a consultation. If you were to say this patient was sent by Dr. So-and-so for consultation regarding his nasal, sinus, ear, whatever problems, then that would be deemed appropriate for terminology of a consultation. Established patient visits don't require the full complement of components that are necessary, but you must have 2 of the 3. And so you can base your visit on the history and the medical decision-making, or the physical and the medical decision-making. Notice that history and physical really isn't listed here as 2 separate components, simply because, as we'll talk about in a moment, the medical decision-making is the most important phase of your evaluation for billing purposes. In the advent of the electronic medical record, most most patients, when they come into your office, will have a CMA or other assistant filling out the basic form for you, including the review of systems, family history, social history, medication list, allergies, and the like. And so with them filling out all of the important data before you see them, it's very easy to get to a level 4 visit if you feel it's appropriate based on the medical decision-making portion of it. So when we look at the elements of an encounter for an office visit, whether it's a new patient or a return patient, the history obviously is terribly important. That's where we make our diagnosis, but we have to include the HPI, the past medical history, which includes social and family history, and a thorough review of systems. The buzzword for this is a 14-point review. And if you're using any form of electronic medical record keeping now, basically that's done almost entirely by your office staff, and will cover all 14 points just by having them fill out the checklist and that being entered by your staff. The exam has a bullet point factors, and that's where you're checklisting your different systems that you're evaluating on your examination. But the medical decision making is really where the coding comes into play. The number of diagnoses possible, the amount of data that you review. So when you see a patient and they bring that 40,000 page stack of papers for you to look at, or multiple discs for you to review, that's all included in the amount of data that you review to help with your medical decision making, and makes the office visit more complex. And whether or not there's risks involved in the procedure helps increase the medical decision making as well. And so that would include, for example, if you're doing an ear tubes, it's fairly straightforward. There's a whole lot of risks are not there, and the planning and evaluation is pretty straightforward. So that would be a very low level of care from a medical decision-making plan. If you've got a patient who presents with hoarseness, smoker, multiple medical problems, has been seen by multiple other physicians, brings in scans that were done at an outside institution and outside records for your review, those are more complex and require more importance in the billing process. So the simplistic clinical approach to coding office visits are basically boils down to the clinical decision making. And this really drives the coding level, because you can support everything else based on this. So the first step is really to look at your patient and to consider how many possible disease processes there are, how sick they are, how complex they are from a medical standpoint. Then you look at how much information or testing you have to review and analyze. And then the complexity of the treatment plan, whether you're considering surgical intervention, multiple medical interventions, or multidisciplinary care such as radiation or chemotherapy. Those all come into account. And as you describe them in your note, that becomes a more complex in terms of clinical decision making. And so we get down to this little basic chart. And so things that are fairly straightforward, and these terms on the left of the chart are the complexity levels that are used for coding. And so if you look across the board here, you've got 3 different areas that you're looking at: the number of diagnoses or management options, the complexity of data to be reviewed, the risk of complications or the morbidity or mortality of the care that you're providing. And you can see that for a straightforward problem, there's very little to consider in any of those 3 columns. The more complex it is, the more extensive material that you're reviewing, and that helps you to decide. So once you develop the complexity of the patient problem that you're evaluating, then it becomes quite simple in terms of what level of coding you can perform. And again, if you did not dictate any of this, you didn't do it, and so it does not count, no matter how hard you want to make it sound. And so if you've got, for example, the number of diagnoses, these help to determine, according to CMS guidelines, what the issues are and the levels of difficulty. And you can see down the board from 1 all the way down to 4. And then the complexity of data, you can add a point for each of these items here, with more points, with more difficult things that you have to review. And those all add up to help you to determine the complexity of the medical problem. Since every year comes out with new codes, 2020 is no different. There's a whole host of new codes that are out there, not too many for the otolaryngologist, but there are a couple of new E&M codes that were developed before COVID-19 came into being. And these top three are interesting because we used to have one single code, 99444, for online medical evaluation that not only did not get used often, it never got reimbursed. CMS and Medicare is now understands that there are some issues that you can deal with on a digital platform. And so there are several new codes that are time-based that allow you to do that. So if you're communicating with the patient online for 5 minutes or less, then it's not reported. But other than that, you've got your 5 to 10 minute period, your 11 to 20 minute period, and over 21 minutes for coding. When the code is intended really for use with an established patient, you could use this for a patient that is new that you've never seen before with proper documentation. And so the clock for this 7-day period begins. So let me just clarify here that there's a 7-day period from when you do this digital exam to when you may see the patient. So if they are seen within the 7-day period of your doing a digital evaluation of them, then you cannot bill these codes. But you can include, if you are not seeing them, reviewing information with the patient, developing a plan with the patient, generating a prescription or test order. So if you've spoken to a patient 5 minutes or more and decided you need to refill their prescription, that is a billable service according to CMS and will be, and you can try, I can't say will be, should be reimbursed by most insurance plans, okay? And as I said, if the separate E&M face-to-face visit or real-time virtual visit occurs within a 7-day period, then this gets wiped out and you can't bill for it. So this is obviously an important area, and I included this in this talk today because now we're doing more and more telehealth and telemedicine, and Medicare has, as of March 6, allowed for this to occur and to be billed appropriately. So the slide's a little bit busy here, but basically, as I said, since March 6th of this year, and until the Health and Human Resources Secretary decides the pandemic is over, these will be in effect. And so now you can do telehealth encounters with patients no matter where they're located within your state. It allows for audio-visual communication, but because of the limitation in patient access, Medicare has waived HIPAA compliance for your platforms. So you can use your standard cell phone or some other device to communicate with patients, and they can do the same. Although most medical centers will require that you do a HIPAA compliant platform. But Medicare will pay for those visits, even if it isn't HIPAA compliant in terms of the platform. And this will cover the common office visits. It covers all forms of physicians and physician extenders, including our nurse practitioners, our PAs, and others. And it is covered at the same fee schedule as an inpatient visit. And you do not have to include the physical portion of it. So again, it comes down to medical complexity of the diagnosis. So if you've got a high complexity, you can bill for a higher level of care. And if you have a low complexity, you can bill for a lower level, you would bill for a lower level of care. This also allows for you to waive deductible and coinsurance that patients would normally have to pay at the time of the visit, so that you don't have to deal with a financial platform when dealing with them through a virtual scenario. It does require, though, that there are some existing patient requirements, so it's more difficult to consider doing this as a new patient, but it is allowed, and human resources will not conduct audits to see that you have conducted virtual evaluations of patients if they're new. And so you can still provide new patient consultations and evaluations on a virtual platform as long as you document them without fear of being audited later and being requested to have those monies paid back. When you do telehealth coding, there's just a few things you need to be aware of. First, you have to establish a chief complaint for the patient. This is something that this is the forms that we're using at the University of Kentucky on our electronic platform. And there's a box that you type in the chief complaint. And then you have to check the boxes that you've identified the patient by name and date of birth, that they're physically located in your state. And that's more for Medicare and Medicaid, but may also pertain to certain private insurance, and that they've agreed to allow for telemedicine consult by agreeing to the consent verbally. And then later on in the evaluation, you also have to indicate that this was done as a digital audio and video component. If you're unable to connect with a patient by video, more than likely it's basically just a telephone call and it's not going to be reimbursed. So it's in the best interest of you and the patient to see them face to face on a screen, whether they have to come to a medical center nearby that has the capabilities or using someone's digital phone to communicate with them. But if you only did an audio, you can check it and you can do the evaluation, but more than likely that will not be reimbursed. And then lastly, you have to indicate the total time spent with the patient. And that starts from the moment you start reviewing their information that is provided by your office personnel, or perhaps they may have had some material sent to you in advance for the visit that was expected to be a regular office visit, but now has turned into a virtual visit. Now let's switch gears for a moment and go from office visits and E&M encounters to procedural coding. So when you're doing procedures on patients, there really is no limit to the number of codes you can report. If you've ever seen a HCFA form, there's about 8 boxes that you could put codes in for with the appropriate ICD-10 coding, but there are extension forms that can be used to add additional codes if necessary. Unfortunately, as you would expect, you wouldn't be paid for as many of the codes as you should. And back in the 1980s and early 1990s, we were getting reimbursed quite nicely for about everything we did on an almost full basis. And I hate to tell you that a full FES, bilateral FES, would often bill out at $24,000 to $26,000, that we're now getting reimbursed somewhere between $800 and $1,400 for the same care and the same risks that are involved with those surgeries. So typically most insurance plans would pay the first code at full value and reduce proportionally the second codes on down, with codes 3 and lower being reimbursed about 10%. When you do your CPT coding for procedurals, you need to make sure that you're attaching the appropriate ICD-10 diagnostic code to it, because if you do a septoplasty and your ICD-10 code is nasal stuffiness, more than likely you will not get reimbursed until you get a correction to that information. So you have to be very precise. You should never worry about how many diagnostic codes you're attaching. The more, actually, the merrier, because they're more likely to be hit with the insurance company as being appropriate. The last thing you want to do is do surgical procedures on patients and not have proper documentation, and you submit them to the insurance carrier only to get them kicked back, and you're still fighting with them and sending further paperwork 3 months later. This is a tremendous toll on your office personnel and expense to your practice, because they're taking time away from other duties to resubmit codes. And so you really want to try and get this done first time and get it right first time. More importantly, you always want to code what you do. Don't consider the insurance reimbursement. You know that they're not going to pay you the full amount, but if you are not coding what you're doing, you're cheating yourself. So you'll always want to make sure that you're appropriately coding for every single procedure you do. And there are resources available with the Academy that help you with coding. And there's a whole set of pages on the Academy website that will lead you toward proper information regarding coding. The other thing is modifiers. Modifiers are two-digit codes that help to explain extraordinary circumstances to insurance carriers. Now, not all carriers will accept modifiers, but as I mentioned a moment ago, if you're doing something and you're using a modifier, you need to, or rather, you need to add a modifier if appropriate. The insurance carriers may just wipe them out. Your back-end people who are doing your billing for you may say it's inappropriate, but if you think it's appropriate, you code it and they can sort it out on the other end. You should not worry about what the insurance companies are going to do to it, because we have no control over that in many cases. We still can submit paperwork toward them to try and get better reimbursement, but it can be onerous. So if you do it the first time correctly, you're less likely to be caught up with your insurance carriers in fighting with them in terms of reimbursement. You can add multiple multipliers to any CPT code. So if you've got a procedure that you perform that's unusually difficult, a 22 modifier is the extraordinary circumstance with an unusually difficult procedure, which you have to document. And then if it's a bilateral procedure, then you can add a 50 modifier that'll indicate you did that on both sides. Now you need to be able to document that that was unusual and difficult. Example being a patient who has had multiple previous sinus surgeries, has recurrence of polyps, has scar tissue, has their normal anatomy is severely distorted. You're using image guidance with that. Those are all indications for documenting this is an extraordinary circumstance with an increased service level, and using the 22 modifier would be most appropriate. On the other hand, if you're doing some procedure where like a uveopalatal rhinoplasty, but you're doing a minimal revision to it and perhaps just a little Z-plasty to the palate, that code may still be appropriate, but you may want to use a reduced services code, like a 50, which is a 52 modifier, and document that, and you'll have much better chance of getting that approved with a limited description of the services that you provided. So again, you want to use modifiers widely, but the global period, which may come to an end in the next few years, is critical for use in determining what is and isn't available on a modifier basis. And I'll go over that on the next slide. So a 50 modifier is a bilateral code, and that pays 1.5 times the fee schedule. So it's not infrequent that if you are coding yourself, you want to put the highest level code at the top. And if you've got a 50 modifier, that may trump putting a unilateral code above it. Now, again, if you've got good billing people in your office, they will automatically do this for you. I tend to want to know what, how I list my codes appropriately. I submit the highest level code at the top and work my way down on my fee sheet that I submit to our billing people. A 62 modifier is a modifier that's using a separate surgical team. And that's probably the most common is when you're perhaps doing a case with your neurosurgeons and doing a transphenoidal hypophysectomy, and you're doing the approach. You're going to use the same exact code as the neurosurgeons do. The reimbursement for that code will then go up 1/4 of what it would normally be reimbursed at. And then you and your neurosurgeons will actually split that. So you'll end up getting 62.5% of the code that you're charging. A 59 modifier is useful for separate sides, same anatomy surgery. So there are some circumstances where doing some nasal surgery and it may consider to be bundled in. And so by adding a 59 modifier, it tells the insurance carrier that it's a separate procedure within the same area. And that sometimes is disallowed by insurance carriers, but still should be coded if you've performed that. And then a 51 modifier is when you're doing multiple procedures. Now, some billers will put a 51 modifier on every second, third, fourth, and other codes, indicating that as multiple procedures, but that isn't usually necessary. However, if you are taking off 2 lesions on the face, and they're the same size in the same location, perhaps on the cheek, then using a 51 modifier will determine that is a separate procedure, so they won't think you're double billing for one excision. Similarly, we still use the right and the left codes, so that can sometimes help when you're doing multiple procedures and you're doing a lesion on the right and a lesion on the left to help signify that those are separate multiple procedures. And then there are some other codes like the 79 code, which allows you to bill for services that performed during the global period. And I'll talk about that on this next slide here. So here are some of the other modifiers that are available. And here's where the global period GP plays a big role. So you've seen a patient and you've got them in the global period. And I think everyone knows what the global period is, although they may not recognize the time length for a global period for certain procedures. As an example, a tonsillectomy is a 90-day global period. A tube placement is a 10-day global period. Almost all endoscopies, whether they're with or without biopsy or excision, are a 0 global period. So you can start your coding for reimbursement immediately on their first postoperative visit. But if you're seeing a patient that's within that 90-day global period and they come in for an unrelated problem, so say you've got a tonsillectomy patient that comes in, now they've got a nosebleed that's unrelated, and you're seeing them for the nosebleed. That's an unrelated visit, and so you'd add a 24 modifier to the E&M code. Similarly, if you're doing if you're using a 25 modifier, that suggests that there's a separate, significant separate E&M code on the day of a procedure. So you've scheduled the person to have a procedure and they're being seen for some other problem as well, then you can use that modifier. The 53 modifier is infrequently used because most people don't know what that is. But essentially, if you are starting a surgical procedure and anesthesia says, oh, blood pressure's too high, or you start and you're noticing excessive bleeding and you have to discontinue the procedure either at the beginning or during the procedure, you can still code for the entire procedure that you were planning on doing and adding a 53 modifier. Now, that does not guarantee payment by the insurance carrier, but it should, CMS guidelines allow for payment there. These next two codes are specific for patients that are travelers. If you're doing a surgical procedure on a patient and then they're moving out of state and there's a global period involved, because your reimbursement for your surgery includes postoperative care, you should and are required to include a 54 modifier on that that indicates you're just doing the surgery and someone else will be doing the postoperative care. Now, that does not include if that someone else is in your office practice. That's if someone else is in a separate practice or a separate location. The 55 modifier is the reverse of that. If someone had surgery, had a tonsillectomy, and you're doing postoperative care on them, they had a tonsil bleed, and they're brought back to surgery, or you're seeing them in the office visit, their insurance carrier doesn't know that you may be a different service provider, and so by adding the 55 modifier, you indicate that you're doing postoperative care. Similarly, if they leave the area and they're being seen by you in the global postoperative period, you want to use the 55 modifier to make sure you're reimbursed properly. A 57 modifier is when you have an office visit and decide on that day that you're going to be performing surgery within the next 24 hours on that patient. That's important because the relative value units for a surgical procedure include the pre-op visit within 24 hours of the surgical procedure. So if you're seeing them for the first time, and it's an example again in the emergency room, and then you decide they've got a peritonsillar abscess and need to be brought to the operating room acutely or emergently, then you would add a 57 modifier to your E&M code, and that would allow for payment of that E&M code, and then you'll be able to bill for your surgical procedure as well. The 58 modifier is when you're doing stage procedures within a global period, so perhaps that would include a forehead flap where you're going to be bringing them back for multiple revisions, often within that 90-day period. And so on your second surgical procedure, you would add the 58 modifier, and the third procedure, the 58 modifier, if it was within the 90-day global period. And then the 79 modifier, again, is if you're doing an unrelated procedure or visit within the global period, And again, that's for surgical patients that come in that have a separate problem entirely. So again, you took out their tonsils and they have a cellulitis in their face and they're seeing you for that. And it's most likely unrelated to the tonsil surgery. Then you could put a 79 modifier on the office visit or procedure that you're performing on that given day. So as I mentioned earlier, you want to list your higher paying codes first on your billing sheet on your HCFA form. And since most of you don't even know what a HCFA form looks like, and hopefully you will never know what that looks like, you want to at least submit that to the biller with priority to the more expensive procedures. Most of your billers will know what the RVUs are for these procedures and will list them accordingly, but it's no guarantee the insurance company will pay the higher RVU first. And so you may lose some reimbursement. I mentioned earlier about the 22 modifier. This is a very important modifier, but should not be used regularly. CMSF and other insurance carriers do audit this modifier for abuse potential. When it was initially described, it was noted to be an unusual procedural service, and now it's an increased procedural service, which means that you're increasing the intensity of the procedure you're doing. There's more time involved, more difficulty in performing the procedure. The patient may be more sick, and the amount of effort that it takes, both physical and mental, may be more than what you would normally do for a standard surgical procedure. So if you want to use a 22 modifier, you must document in your operative record, and these are for surgical procedures. These are not codes that are used for E&M. So you must document in your dictation the complexity of what's going on: distorted anatomy, scar tissue, increased bleeding. Any of those factors are important to document with your surgical record. For otolaryngologists, we do a fair amount of procedural in the office, and we've got endoscopy codes that are available. Most of you would recognize these codes without my listing the descriptor on it, but the 31575 is the flexible nasal laryngoscopy code. Flexible nasal laryngoscopy code basically means that from the start of the procedure to the lowest level, everything that you're looking at is included in that code. So if you're going to be performing a scope of their larynx and you're looking in their nose, their nasopharynx, and down to the larynx, every part of that anatomy is included. If you look at the reimbursement for that, you would think that that would be a much higher level of reimbursement. Whereas 31231, which is just a nasal endoscopy, is billed or potentially billed at a much higher level. And the 92511 code, which is infrequently used, is nasopharyngoscopy. So that's where you're looking at the adenoids, you're evaluating velopharyngeal incompetence, you're looking at the posterior nasal cavity and the choana to see if there's any blockage there, but you're not looking down to the larynx. And so the reason the 31575 code is reimbursed at a much lower level is because CMS has got a pool of money that's associated with each code, and it's revenue neutral. And so the more people that are doing these procedures, the thinner the pot becomes. And that doesn't just include otolaryngologists, but it includes family practice docs that are doing flexible scopes and ER docs doing flexible scopes. And so that has diluted the pool significantly so that it does reduce the reimbursement for that particular code. That's not a reason why you should not educate your colleagues on how to perform the procedure, but you have to be aware that it isn't reimbursed at a level as some of these others. So if you're just truly doing a nasal endoscopy, a nasopharyngoscopy, don't just say, oh, I'm just going to go and look at the larynx also because I'm there. Because once you do that, you're now performing a flexible nasal laryngoscopy, and then you have to build that code. And these codes are the same whether they are, well, the 92511 and the 31231 can be rigid or flexible scopes. And the 31575 specifically identifies a flexible scope. In your practices, you'll want to make sure that you've got templates available for your common procedures, which will help in terms of your documentation. And so that way you can actually indicate the binocular microscopy that could be performed with a myrigotomy and tube placement, a cerumenectomy, or intratympanic injections. It can allow for describing the instruments that are used as well, because that's a critical part of getting reimbursed for something as simple as a cerumenectomy. And we all know that isn't always that simple. Similarly, having templates for your endoscopies that you can fill in are very helpful, because they'll allow for the indication for the procedure. And so whenever you're doing a procedure in an office setting, you always want to have the indications for the procedure documented in your medical evaluation. Otherwise, they may not be reimbursed. Another topic in our area that's always a challenge is trying to get reimbursement or approval for performing a rhinoplasty. And here's where we get into the cosmetic versus the functional rhinoplasty. We all have tried, and many of us have failed miserably in trying to get approval from insurance companies for a rhinoplasty. But you've got to be able to document that the anatomic structures, primarily the external nasal vaults, is causing significant and symptomatic airway compromise, which can lead to and cause the patient problems with sleep apnea, acute recurrent rhinosinusitis, and that they've tried and failed medical management. Many insurance plans will also cover the deformity if it was caused by nasal trauma within an 18-month period. Some plans cover only 6 months or 12 months, so you'll have to check with your insurance carrier to see which would be most which would be covered. And then the ICD-9-10 codes are important for making sure that you have the appropriate diagnostic codes available. And one code that frequently gets missed is the acquired nasal deformity code. So you want to make sure that ICD-10 code for acquired nasal deformity is included. And there's also a whole host, if you've not seen the ICD-10 codes, they're insanely extensive on the actual cause of the trauma, whether they're hit in the nose by an airplane engine or the wing of an airplane. That's all included. If they're bitten by an alligator, that's there. And so adding these additional codes may be helpful, but often are unnecessary. But if you don't have photographs to submit your insurance plan, you're not going to get covered for functional septal rhinoplasty. So basically, the bottom line for insurance companies is if they look at the pictures and the dorsum is straight, you have very little chance of success in getting this approved. Now, taking proper photos are useful and are required for documentation for a functional septal rhinoplasty. A few other talking points for surgical procedures that commonly come up. Your coders will often tell you that if you're doing a uveopalatal with a the tonsillectomy is bundled with the uveopalatal. However, I still believe that you should code both procedures. Sometimes the insurance company will disallow the UPPP for a variety of reasons, but will allow for the tonsillectomy, so you will get partial reimbursement until you end up fighting them. The Academy has a actual sheet on the website for coding that helps support the uveopalatal for surgical reimbursement for sleep apnea, obstructive sleep apnea, and you could utilize that. There are other diagnostic endoscopy codes that are bundled. And so again, your billers may tell you that you can't do a laryngoscopy with an esophagoscopy, which is not true, or a laryngoscopy with a bronchoscopy, which is often bundled together. But if you can explain why you're doing both, so if you're using the laryngoscopy to look through to get to the trachea and they have no symptoms or signs of problems with the larynx, hoarseness and the like, then you'll have very little success in getting approval for that. But if they're hoarse and have other laryngeal symptoms, as well as having tracheal symptoms, and you're trying to evaluate what's going on with their airway, then you can certainly code for both, and that's where that 59 modifier really comes in handy. You'd code for the bronchoscopy, a 31622 code. You'd add your laryngoscopy, 31526 code. You're using a telescope. That would allow you to do the magnified code. And then you put a 59 modifier on the laryngoscopy code. You do not need to use modifiers with the surgical laryngoscopy codes. And so here are the opportunities that have been added years ago in terms of doing the coding for the laryngoscopies. So we've got at least 6 different laryngoscopy codes that have differentiation with and without magnification. And now that we can use operative, we can use a telescope instead of a microscope. In the past, if you did not use a microscope to do these procedures, and you just use a telescope for diagnostic or therapeutic interventions, you would not be reimbursed. Now the terminology is loosened to allow you to do both. Middle terminal resection, if you're going to be doing middle terminal resections for concha bullosa, if you use an endoscope, you can bill with the 31240 code. If you do not use an endoscope, you can trim that middle terminate and that will not be reimbursed as a for a middle terminate. But since January of 2018, both the excision codes and the submucosal resection codes, 30130 and 40, identify that it could be either an inferior or a middle terminate that's involved for the resection. So there are some codes that you can still use, although the endoscopy code is a better code for the concha and will reimburse better. There are also frequently some questions regarding radiofrequency ablation. And basically what we're talking about is when we use the coblator, we're destroying membrane. And so there's radiofrequency ablation codes for the inferior terminates, and then there's radiofrequency code for the tongue base. But if you're going to be doing any radiofrequency ablation of the palate, that's an unlisted code. There is no specific code that identifies that. So this is a good opportunity to segue into unlisted codes. This is the code you never, ever, ever want to use unless you absolutely have to, because there's no guaranteed reimbursement. There's no specific RVUs associated with an unlisted code because it can run the gamut. Each area, anatomic area, has a unlisted code for it. So you've got enlisted codes for the nose, for the palate, for the tongue, for the head and neck, in all the different areas. And so there's a boatload of 99 codes that are out there, and that's how they're usually identified, as a 99 code. These are the codes that are most commonly used when new procedures are available, but they have not gone through the evaluation by the committees that assign new codes. So if you're going to use a 99 code, you want to describe in very specific terms what you've done, as with every other procedure, but the difference is you want to compare it with another code in that same area and explain why it's more or less value than that particular code. And that's terribly important because the insurance companies have no clue. And as you remember, if you've ever talked to an insurance carrier's peer review, these are not ear, nose, and throat doctors you're talking to. These are retired pediatricians and obstetricians and family practice doctors that are working for insurance companies to look at coding. Now, you can request an ear, nose, and throat doctor after you go through the formal process of talking to a physician that does not really know your specialty. But if you can describe it to them in more detail in your operative report, you're more likely to get reimbursed. You cannot use a modifier on unlisted codes. That's important because modifiers are used to describe different complexity or evaluation of a code that has a descriptor. When the code does not have a descriptor, you can't increase or decrease the level of it, nor add any other modifiers to it. So any modifiers you think you might want to use on a 99 code, throw them away, they're useless. And so again, for documenting the unlisted code, you want to have a clear description of what you've done and whether it was performed with or separate from other procedures on that same surgical experience. And if there were any other extenuating circumstances that complicated the service or the procedure. and you want to include, because our views are time and effort based, you want to make sure to include the amount of time it took, the effort it took, and if there was any specific additional equipment that was necessary to provide the service, and whether or not that service was performed on one area or multiple areas, i.e. the number of times the service was provided. Now this code, the 61782 code, is utilized for basically what we consider image guidance, and that's most commonly used for our nasal and sinus codes, but can be used for other areas in the head and neck. This is an add-on code, so it has to be reported with other codes, specifically other sinus codes or other skull-based codes, although many of the actual skull-based codes include image guidance in it. And so you can describe this, use this when you can document the reason why you're doing this. If you're using image guidance for a disease that's in revision cases, complex cases, and the like, and there's a whole list of situations here that I won't go into individually, but it's not very hard to document why you're using an image guidance code. And we do have a position statement. The Academy has a position statement that you can print out and send to the insurance carrier. And some practices will send this routinely when they're submitting this code. There's another code that otologists are using for transtympanic injection, and this could be anything that goes through the ear canal. And so this code has a 90-day global period. So if you're performing it multiple times within that 90-day period, you have to put on the appropriate modifiers. And this can cover all sorts of care, including steroid injections, drug injections, and you've got to use the codes that are based on the descriptors. And then you have to describe the medication that you provided, as well as the dosing of the medication that you provided to be able to claim this code. Well, now that you've learned how to properly code, you want to go back and audit your practice. And perhaps every 3 or 6 months, you want to submit to your biller the common codes that you typically use and have them run an analysis on those codes based on insurance payers to see what you're actually getting reimbursed and where you're failing. And it's important that that be done on a regular basis because it requires very little attention on your part after submitting some codes. And it may be just a question of, let's see if we are getting paid for the 61782 add-on code for image guidance or not. Okay, that may help you in determining whether or not you're actually going to perform that. More than likely it shouldn't, because that's the whole purpose of using image guidance, but some practices use it a little bit more frequently than others. But auditing your practice is terribly important to you. Appeals letters is another thing that you must do. There's, again, on the website, but every organization that you belong to has a group that will help with insurance reimbursement. So the American Rhinologic Society does, the Allergy Academy does, the Otology Academies do, and even the American College of Surgeons, if you're a fellow of the American College of Surgeons, has their own separate reimbursement hotline that can help you dramatically in getting through these issues. And so rather than trying to reinvent the wheel for appeal letters, use something that's been proven successful by your academy. So in conclusion, we have some take-home messages here that I'd like to share. First, code it yourself. If you can do it, you should do it. And code everything you do. Don't cheat yourself. If you've done it, code for it. Please don't forget to use modifiers when appropriate, and your dictation must support what you're doing. So if you haven't dictated it, you haven't done it. We talk about upcoding, where you increase the level, usually with E&M codes for the office visit, outside what you actually have documented. And you will get audited if you're using level 5 codes very frequently. CMS does that audit on a routine basis. And the people that do the audit for CMS will charge your practice upward of 100% of your reimbursement. So it'll cost you at least 100% more, or double what you got paid for fines that are associated with it. But they also consider downcoding to be bad, and you can be fined for downcoding, because every patient that comes in should be billed the same. So if you decide that, oh, they don't have enough money and you want to downcode them, if you document something and you downcode it, you can be audited for that as well. So, and if you don't have your last take-home message here, if you don't have the proper diagnostic code, the ICD-10 code for your procedures, then you may not get reimbursed or will take longer to get reimbursed. So I don't know how many people do we have on this talk here today. We've got a bunch. I've been in communication with Jim Denaney, who is the EVP of the Academy, and they have allowed us to offer complimentary travel grants for all viewers of this presentation to a presentation I'm going to provide in October in the Bahamas. And this actually includes all registration fees, all hotel, transportation, and meals. So if you were participating in this conversation today, you're going to get a free trip. Or not. Sorry, folks, it's April 1st. I'd love to share. It's tough to make jokes and decisions on this time of year, but I thought something like that would be nice. All right, at this point, I'll be glad to take any questions. You're more than welcome. We've got another few minutes here to send me questions by chat if you'd like, or activate your microphones. Again, sorry that you're not going to go to Atlantis on the Academy, but if you saw Dr. Comer's presentation, Dr. Postma's presentation yesterday, putting Dr. Comer at risk, this is the risk I put at you today. So thank you, Dr. Comer, for sharing your esophageal anatomy with us.
Yeah, that gave me flashbacks to 9 years ago.
So I'm glad that Dr. Liebman thought that I was serious regarding the Atlantis trip. Sorry about that. Can I answer any other questions in the next few minutes that we have before the next presentation? Feel free to type something in your chat or speak up.
I've got a quick question. Oftentimes, I'll give you a good example. We'll do like a very like super morbid obese patient with a massive goiter, and I'm like, oh, we should bill a 22 modifier for this. This is hard, right? It's not your standard thyroidectomy. And then the attending's like, oh no, like we never get paid for that. Like, can you explain the rationale for like why you still want to include that modifier, even though you might not get reimbursed for it?
Well, for one thing, you've done the work. So if you've done the work, you should submit the expense. And I disagree with your attending. I think that it costs nothing to add a 22 modifier to the code and to document the extensive nature of the surgery. We've all done surgeries on thyroids where they're a chip shot and they come out super easy. You find the parathyroids and nerves standing there and skin to skin in under an hour, and you're feeling pretty good about yourself. And then you get that case where you're doing a mediastinal dissection, 4 hours, 5 hours into the case, you're pulling up the gland, you're struggling to find the nerve, you can't find 2 of the 4 parathyroids, you want to decide whether you got to have to do an injection or not. Those are complicated cases. Those are increased levels of service. Those should be billed at a 22 modifier, and insurance companies will reimburse a 22 modifier. Now, Medicare probably will not, but if you code and you don't get reimbursed, you have not lost anything. If you don't code and you could have gotten reimbursed, you are losing something. So the rationale is, if you've done it, code it, bill for it, period. And then you can always have that fight with the insurance carrier later. If you talk to your billers and the biller says, this insurance plan never covers a 22, well, so be it. You can't send an appeal letter in for that. However, there are many insurance carriers that will. And so more than likely, especially as the resident dictating the case, you don't actually know what the insurance carrier is. And so you may not know if they're going to be paying for it or not. But you know that you spent 4 hours, 5 hours on a thyroid, which often takes so much less time and was so much more complex. And so you need to be able to document that. Does that answer your question, Rob?
Yeah, thank you very much. And then I guess as a sort of a follow-up to that, does it help to include certain modifiers like that 22 modifier in that case? Because like don't codes get recalculated after every so often?
The RVUs will change slightly, and we didn't have really enough time to go into how codes are established and developed. The each specialty has a member two members that are on the 3P committee that meets with the RUC. And the RUC is the CMS equivalent. And we're basically consultants to CMS. They don't have to listen to what we say, but they will listen to our conversation. But if you're taking a code that crosses over with neurosurgery and maybe endocrine surgery also, and if you add a new code, they're going to be taken away from the pot for those entire groups. And so the reimbursement can be reduced. That doesn't happen very often. But when you look at the value of the relative value units that I talked about earlier, we got a nickel more. Well, you know, we're not getting a lot of reimbursement year by year, but you shouldn't really worry about that. You really need to worry about making sure you're billing appropriately and correctly. So I think we're out of time. Thank you for those questions. Thank you for allowing me to entertain you this morning, and wherever you are, have a great day and stay safe.